Good morning, colleagues. So, in terms of a public health problem, which should be one of our focuses in this hospital, in this institute, uh, cancer cervix is there, and it's significant. It's not glamorous like breast cancer because that gets drummed up because it happens to women and celebrities, and there's a lot of talk about it. It's a problem of have-nots of the society, the strata, and it is mired in a lot of, and there's a lot of industry and technology involved, and it muddles up the real picture about what should be done for prevention of cancer cervix. But regardless of these controversies, there is some data that stares us in the face. Across the world, over the last 3-4 decades, there is a decreasing trend, and it's practically halved. There was no vaccination. This is the single biggest evidence of the fact that vaccination or no vaccination, the incidence is falling. Some factors are attributable. One of them is lifestyle, the other is family size, and so on and so forth. So that's the one story, but it remains the focus of people, and time and again, the vaccination story crops up. Of course, it's a lifestyle disease as well. Lifestyle as in the lifestyle of have-nots. The second thing is adoption of technology. This disease, the second focus that we have in this country today and in the state of Uttar Pradesh is that if there's something that you can detect early and treat it, then accounting for the lead time bias, there is some data that early detection saves lives. That's clear. It can't be said for many other cancers, particularly screening studies where you simply have the factor of lead time bias showing you an artifactual increase. Now, this is why the focus of the government of Uttar Pradesh and in the country is on screening of 3 diseases: breast, oral cavity, and cervical cancer. This is the second thing. Now those who are screen detected, they have a different trajectory. They are handled by the gynecologists. That's a community problem, what to do with them, how to detect them. But those who have overt disease, inevitably, other than the most early cancers, come for radiotherapy. The third storyline here is that technology is advancing, and radiotherapy, like any other strategy, should be selective. In other words, it must just focus on the disease, and there should not be collateral damage. The buzzword that came, in the 90s and 2000s when armies were invading and bombing of people, talking about humans as collateral damage. The collateral damage here is normal tissues. That's a real problem. So technology comes, and technology adoption should ideally come with randomized trials, but in actual fact, technology adoption happens with affordability, scale, willingness of people to adopt. And so we also gradually transit, keeping in line with fashion, but more importantly, intuitively, it makes sense not to treat areas that don't need treatment. So this story, the theme, is going to be the subject of today's discussion. The discussion really is focusing on radiotherapy treatments. That's a no-brainer. It's a 100-year-old technology, but adoption of technologies where you are able to reduce morbidity, it's a worthwhile goal for the cancer-afflicted patient. So colleagues, Dr. Shalini Singh and colleagues will be talking about it. Dr. Shalini, please.
Thank you, sir. So cervical cancer, as Dr. Shaleen has alluded just now, is the second most frequently diagnosed cancer in the world, and it's the most common, second most common cause of cancer death in the women, with maximum proportion of patients reporting in Asian countries. And the most common risk factor is human papillomavirus, which accounts for more than 90% of all the cervical cancer. The other is the lower socioeconomic class, the multiple sexual partners, the early age of first sexual insult, and the high parity. So as has been just now, Sir has alluded, is that there is a decreasing trend both in the incidence and as well as the mortality over the past 30 years. And it has just doubled, the trend has been decreasing, and it is just, it is twice what was there in 1992. The lifetime risk of developing cancer in a woman is about 0.7% during their lifetime. In India, if we see, the incidence rate is 14.7 per lakh women. And we also find a similar basically picture of decreasing trend in the incidence as well as the mortality. However, compared to the Western data, which we just now saw in the previous slide, we do find that it's still a public, basically, a problem in India, and the rates are not as low as compared to what is there in the Western counterparts. If we see the state-wise basically changes which has happened over the period of time in terms of the cervical cancer incidence, I've picked few. I mean, it was a huge lot of big table, but if we see come to the Uttar Pradesh, we find that this percentage change in decrease in the incidence is slowly decreasing in Uttar Pradesh, while in certain areas like Tamil Nadu registries and in Andhra Pradesh registries, you find that the trend is quite high in terms of the incidence decreasing there over the period of time. So this decline has been attributed to multiple factors. One is an increasing in the average socioeconomic levels, the improvement in genital hygiene, and thereby obviously diminishing the risk of persistent infection with high risk HPV virus. Reduced parity now because people are aware, and the ladies are working, and the diminishing prevalence of the STDs. When we come to cervical cancer, the staging primarily has always been clinical because it's a site which can be easily accessible for the clinicians. And recently, however, in 2018, the the International Federation of Gynecology and Obstetrics added on imaging into its staging armamentarium. And that was to basically take into account the lymph nodes in the staging system. So there has been a change in the staging system, and the lymph nodes, which are more basically prognostic factors, have been included in stage 3C1 and C2. So when the disease, just to elude in schematic form, and so when the disease is basically microscopic or is confined to cervix, it is stage 1. When it goes a little bit beyond the confines of cervix and a little bit in the adjacent soft tissue or the parametrium, it is stage 2. When it goes below into the lower third of the vagina and it is reaching more laterally into the pelvic wall, or it has gone into the nodes either in the pelvic or para-aortic, it becomes stage 3. And something which invades the bladder and the rectum, it is stage 4A. And the ones which go beyond it, like in liver or in other organs, then it is stage 4B. So that's what the staging is generally. The options are more of like surgery or radiotherapy in combination with chemotherapy, and or sometimes after surgery, based on the pathological factors, patients may require radiotherapy along with chemotherapy. And the current standard of management in locally advanced cervical cancer is concurrent chemoradiotherapy, and this is based on this NCI announcement after these trials which carried out and showed that you can improve overall survival beyond radiotherapy alone by adding chemotherapy to the armamentarium. So now for locally advanced cervical cancer, it's concurrent chemoradiotherapy, which is the treatment which should be followed. So generally, to elude back again, so for early disease, it is the surgery, which is considered, and anything beyond stage 1B3, where the disease has basically gone beyond the confines, and you then definitive chemoradiotherapy along with chemotherapy and radiotherapy and brachytherapy boost is the treatment of choice. And in very advanced diseases, it's palliation either in form of chemotherapy, radiotherapy, and sometimes supportive care as well. So what is external therapy? Just for this audience, which is not exposed to radiotherapy, is it is just a high energy X-rays which are used to kill the cancer cells, and these are the machines which deliver these high X-rays. And when we say external therapy, it's that means it is given from far off distance from the patient. And what we basically include as a volume when we treat these patients is cervix along with the uterus and along with the probable lymphatics which could be involved with the disease. So that's a big volume which we include when we are giving an external radiotherapy, and the indications are based either pathologically after surgery. In advanced case, as I alluded, it is the radiation oncologist domain, and so all advanced cancers receive radiotherapy, and in palliative situations, in order to take care of symptoms like bleeding, discharge, we give palliative radiotherapy. So for radical radiotherapy dose, it's around 45 to 50 gray, which is given over a longer course of time, which is around 5 to 5.5 weeks. Brachytherapy, which is the is actually the today's mandate and discussion, which we would be more discussing about, is in something which is an integral part in the management of cervical cancer, and the radioactive sources actually are placed inside the patient using these applicators. So there are multiple type of applicator which goes into the uterus and around, they are placed around the cervical area, so that we can deliver very high dose of radiation therapy, as well as because of the property, the way these radioactive sources are, there is a rapid fall of dose, so that we can prevent the doses to the bladder and rectum. So beyond external therapy are actually giving a boost to these patients in form of brachytherapy in a doses which the external radiotherapy cannot achieve because of the surrounding normal tissues which are limiting the doses to the area. So basically it is given in a fractionated manner. So in SGPGI we give 7 gray per fraction in 3 fractions. It's a OPD procedure. Patients come in the morning, a short anesthesia is given because you put an applicator, patient needs to be pain free, and it is totally the the radioactive sources. It's just now it's through a remote control, so the radiation protection is there for the personals who are using it, and the patient goes off in the by afternoon and evening. And why it is important is, this is basically a study, a SEER data by the United States. It's a study which was done in 1998 to 2009. And at that point of time, what people in United States started to do is to utilize a lot of other external beam therapies, like using more conformal therapies like IMRT or more of stereotactic radiotherapy to deliver a high dose, or trying to mimic to deliver a high dose similar to brachytherapy. And what they found was that those patients who did not receive brachytherapy, the survivals were definitely poor. It was poor to extent of 12% in terms of overall survival. So brachytherapy cannot be, you need to give brachytherapy to have a good control over the local control over the disease and over the overall survival. You cannot escape brachytherapy in the armamentarium of CA cervix. So traditionally, brachytherapy has been generally, when we did not have a lot of new imaging devices like CT scan into the radiotherapy departments, we used to use X-rays for our management, and this has been done in our department. It's still being used in many areas in the country where we basically visualize the applicator. So as you can see in the schematic diagram, this is an applicator which is put in the endometrium, and this is near, just actually hugging the cervix and the vagina. So this is the applicator. It is actually a dummy which you can visualize on an X-ray. And this is the two applicators just hugging near the cervix, and this is the os. So basically, this is what we used to take an X-ray. It's an orthogonal X-ray, one anterior and lateral. And on an X-ray, we use a virtual point is put, which is point A, which is defined by going 2 centimeter above the os, is 1 and 2, and 2 centimeter lateral. So point A will be both on right and left. And here we used to basically, for planning purpose, was the point where we used to prescribe, and this point A was supposed to suggest or mimic or surrogate the tumor target. And there is a decade of experience of using point A for prescription, and people found it quite convenient to give brachytherapy by using this traditional way of treatment. But when we come to the results, when we basically start seeing the result, what we found was that in early tumors where we could achieve a good amount of control, something was not happening in the advanced stages. So the advanced stages were having a poor control compared to what could be achieved by early tumors. And therefore, people found that this point A actually was not correlating either with the central recurrences and neither with the complications. And that led into people working more and saying what needs next to be done. And what they found was that for having a good local control, we need to basically escalate our radiation doses. So if a volume is more, if we give just 85 gray, the local controls are 86%, but if the volume is small, the same 85 gray will have a better local control. So every 10 centimeter cube of volume required more or 5 gray. And to have a 10 gray, this 10 gray would have a 5% local control. So this is 75 gray. So in order to have a local control up to 95 gray, you need to escalate the doses that much. So for escalation, if we escalate that, we may basically achieve a good local control, but at what cost? At cost of toxicities if we define by point A, because we don't know what is the dose which is going to the bladder with such high doses, what is the dose which is going to the rectum, which is just lying behind it. So, and this was eluded by these basically dose effect relationship studies, where they found that if there is a steep rise in the late toxicities if the doses to the rectum are increased beyond 80 gray, and similar was seen in the urinary bladder. And thus came that if we can draw this disease, we can visualize it using the CT scanner which came into the radiotherapy departments. Probably if we can basically optimize the target cover and decrease the dose to the rectum and the bladder which are near to it. So this is just a schematic diagram. This red is the tumor, and this blue is basically the dose which is intended for this tumor. And you can see this is the rectum which is lying. So a lot of rectum is coming into this picture, and this is the bladder which is coming into the picture and is basically receiving high doses, which is the 100% dose which is being given to the tumor to have a control. So with imaging, since we now know it is receiving more of these doses, you can basically with the computerized mechanism can optimize the target cover and decrease the dose. So we did this in this case, and we could reduce the volume of that target of the rectum and the bladder in both the case, and did not compromise on our target cover. So this would have bearing in the expression of late toxicities in this case, in the patient. So patient would have less late toxicities and her quality of life will be better. And thus we would basically, this transition from 2D to 3D CT image based brachytherapy, we will be presenting an experience. Brachytherapy has evolved. It requires experienced team with special skills, and it's a teamwork between a radiation oncologist, medical physicist, medical technologist, and anesthesiologist, because these patients are taken under spinal anesthesia. I now basically invite my resident, Dr. Bonnie, for basically telling our data. Thank you.
Thank you, ma'am. Till 2016, our department had solely been practicing X-ray based brachytherapy, as it was explained by ma'am. Thereafter, CT-based brachytherapy planning was also introduced into department practice. Now, following are the comparative results of the two audits done in the department. One is of 198 patients who were treated by point-based brachytherapy with a radical intent, done in the period from 2008 to 2013. The other is of 90 patients treated via CT-based brachytherapy with a radical intent, done from the period 2016 to 2021. Looking at the results, we see that the median age of presentation has significantly lowered from 54 to 50 years, with most patients now presenting to us before the age of 50 years. In both the two groups, most patients were postmenopausal, had a good performance status, and about a third of the patients had some form of comorbidities. Most patients presented to us with complaint of bleeding or discharge per vaginum, and the median duration of presentation has reduced significantly from 5 months to 4 months. Importantly, the maximum tumor dimension has significantly reduced compared to the previous cohort. Although this difference might seem tiny, but remember that we are dealing here with tumor volumes. So when the dimensions are translated into cubes, the difference is not so tiny. Grossly on examination, the tumors are not so different, and on biopsy, 90% of the patients had a squamous histology in both the two cohorts. Looking at the staging, patients are now presenting to us at a more early stage. As it is evident from the data, the proportions of stage 2 patients has nearly doubled compared to the previous cohort. So prognostically, the latter is a much better cohort. Looking at the treatment characteristics, there has been a rise in the number of patients being started on neoadjuvant chemotherapy first, as opposed to being taken up straight up for concurrent chemoradiation. This is largely attributed to the logistic issues of dates due to the increase in the total number of patient influx at our department being treated with radiotherapy. All in all, most patients received concurrent chemoradiation. The external radiotherapy doses were identical, but in terms of brachytherapy, the doses were hotter by about 16%, from 6 grays per fraction in 3 fractions to 7 grays per fraction in 3 fractions. Also, we are now completing the overall treatment more significantly earlier by a week. In terms of treatment morbidities, there was no difference in the acute toxicities encountered during the radiation treatment, with maximum proportion of patients presenting to us with grade 1 proctitis or grade 1 cystitis, which were managed conservatively. But looking at the late toxicities, there has been a significant reduction in grade 3 rectal and bladder toxicities seen on follow-up compared to the previous cohort. Now looking at the treatment response, 63% of the patients had shown a complete response to external beam RT and 74% in our cohort. But with the addition of brachytherapy, that has improved to 83% and 94%. And looking at these figures, the figures are significantly different at 3 months post brachytherapy. Looking now at at a follow-up period, at a median follow-up period of 3 years, the number of patients that were alive, dead, and lost to follow-up were largely similar in both the two cohorts. Although figure-wise, there has been an improvement in terms of local disease-free survival and overall survival, but that difference is not statistically significant. But if we look at the figures stage-wise, there has been a significant improvement in terms of both local disease-free control as well as overall survival for stage 3 patients. Going by the literature, our treatment outcomes and toxicities are comparable to the international studies that have been done. But most importantly, one of our published historical, compared to our published historical records, there has been a significant improvement in terms of toxicity as well as survival. In my conclusion, I would just like to assert that dose escalation with CT image-based brachytherapy planning is possible with reduced toxicity and improved survival outcomes. Hence, it is our standard of care. Thank you.
Thank you, Bonnie. So what we just came to know was that tumor need radiotherapy, and high dose basically is required for good tumor control, but at the cost that the structures which are normal structures should receive dose as low as reasonably achievable. And as I had alluded, that bigger tumor needs more dose, and that will definitely reflect in terms of local control if we apply on certain volumes. There is an evidence, and basically which also comes from our study, is that normal structures do not like doses, and this is one of the study which showed that 90% of the patients would develop some bowel habits after radiotherapy, which impairs the quality of life, and there are serious complications even after 10 to 20 years of treatment in these patients. And patients might have rectal bleeding, they might have increased urgency to go for micturition and incontinence during micturition. These are all long-term sequelae the patients may have, and even if they are having good control in terms of their disease, their quality of life is impaired. And this is a seen in the 2D era, that the grade 3 morbidities were to an extent of more than 10% across all stages. And so again, the need for this image-based guided brachytherapy to decrease these toxicities. And this is one of the larger studies recently has been published with a median follow-up of 51 months. And what it shows is this is an image-based brachytherapy studies using an MRI, using applications along with some interstitial needles, where it is evident that the long-term toxicities, whether it is gastrointestinal or genitourinary or vaginal, are decreased to an extent of 8 to somewhere around 6%, and grade 4 events just 1 or 0.5%. So that basically is very encouraging in terms of that you are able to give, you are able to reduce the toxicity in these patients. And if you see the controls, they are extremely very good across all the stages, something which was just 30–40% in stage 3s, which I basically shown in my first slide. Now it is up to an extent of around 86 to 81%. That's very good control. Although, did it have an impact in overall survival? Well, it still is at that level, and people are working on it in order to improve what else can be done to improve the overall survival. So we have basically achieved good pelvic control, good disease-free survival, but the overall survival is still modest as it was earlier in advanced cases. So the limitations of our study was that it's a retrospective audit, and the comparison with the historic controls, it's well recognized. There was a difference in patient selection, there was a change in age, menopausal stage, tumor dimensions at onset, and differences in the stage, which could have impacted the way the basically was seen in our data and outcomes. Nevertheless, the dose escalation with brachytherapy, we did find that it had a better local control and improved survival, at least in advanced stages, with reduced toxicity. So this is very encouraging for us, for our patients, gynecological patients, and is presently a standard of care in our department and institute. Thank you.